I'm a giant compared to no. So it's always a tough act to follow with Nathan. So I'm going to be a bit nervous to begin with. But I'm going to talk about non-pharmacological interventions for neuropsychiatric symptoms of dementia. So I'm Dallas Seitz. I'm a geriatric psychiatrist. I work in Kingston area. I provide consultation support for about 10 long-term care homes in a variety of regions, and I really enjoy my long-term care work and see some really great work that happens in long-term care. And so I'm going to speak a little bit about the evidence for non-pharmacological interventions and also some research that we've been able to partner with some of our long-term care homes to look at some non-pharmacological interventions for symptoms. So in terms of research and other supports, here's my... So much of what I'm going to talk about, I actually had the opportunity to do some reviews looking at best practices in non-pharmacological treatments for behavioral symptoms of dementia, including working with Dr. Herman. And we published this in the Journal of the American Medical Directors Association, so that's one of the big long-term care research journals. And we looked at both the efficacy, so how well do some non-pharmacological interventions work, but also the feasibility, how likely we would be able to pull these types of research studies off in sort of the typical long-term care homes where we work, because we figured that would probably be a biggest barrier to some of these research findings being applied into routine practice. So in our review, and this is probably not a surprise to any of you, some of the types of interventions with the best evidence, by far training caregivers or frontline staff in management strategies and communication, so things like a gentle persuasive approach or similar approaches. Mental health consultation, so that's helpful to know that there's some evidence for what I do when we're called in to come and assess patients, and a lot of what we do, like Dr. Herman said, is ruling out pain, potential contributors to behaviors, help facilitate non-pharmacological treatments and medications when appropriate, participation in pleasant events, exercise, music, and various forms of sensory stimulation, including things like massage, snoozling, aromatherapy. So I'm going to focus a little bit on participation in pleasant events, because this was one area that there is a fair bit of research literature on. And what they've shown in terms of how much of a dose of pleasant events do you need to provide for people in long-term care, you really need to be able to provide one-to-one interventions about 3 times a week for about 20 to 30 minutes. So that seems to be, in the research literature, those types of approaches, that sort of intensity seems to work best, where you can have some carryover effect from one pleasant event that's scheduled to another. And the types of behaviors that seem to respond well to this are verbal agitation and physically non-aggressive agitation, like wandering, pacing, sort of rummaging through things where it's thought that there's probably a lack of stimulation and boredom that's contributing to the behaviors. And so pleasant events seem to work well for that. They also work well for apathy, so getting people a bit more engaged in activities in their environment. However, when we looked at how feasible, if we were to take these research studies and try to roll them out in Kingston or some other typical long-term care homes, often what they do to provide the pleasant events is they parachute in people to provide them, recreational therapists as part of the research study, or music therapists as part of the research study. So not something that every home, like Dr. Herman said, may have access to or have enough resources to provide that one-on-one or individualized. Or they think it's pretty reasonable to ask frontline nursing staff to just find an extra half hour in their day to do pleasant events. And we know that that's just not feasible. I think everyone does the best they can with the time and the resources and documentation and care that needs to be provided. But it's pretty hard in a lot of environments for to take that time out to do just pleasant events for things. And some things were expensive as well, but that wasn't the biggest barrier. It was more relying on sort of specialized programs, or really having quite probably unrealistic expectations about time that people would be able to provide them. So what we, working with one of our nursing homes initially and then with 7 additional nursing homes, we came up with an idea of looking at whether we could use volunteers to provide one-to-one pleasant events. And this does happen in some homes, but in a lot of homes we were working with, they all had volunteer programs, but they weren't directly involved with people with dementia. And there was a bit of reluctance or at times worry about having volunteers work with people with dementia. So we wanted to look at whether trained volunteers could provide personalized one-to-one activities for people with dementia. So as I mentioned, some of the barriers to non-pharmacological interventions, we have these limited access to specialized services, limited time. It's a very time-pressured environment, and I only get to see a part of it as a consultant, and I can tell people are busy. Most activities in nursing homes tend to be provided in group format, and that works well for a lot of people. But I think we all know people who get overstimulated in large groups, and also at times, there may not be activities that are suited to the individual. There may not be groups or activities that people really, really enjoy. So it doesn't work for everyone. And we didn't have any programs available to engage sort of community members and volunteers to work with people with dementia, which we thought would be great. If there's any way to get our community more involved and interested in supporting long-term care and this really vulnerable group of people, we thought it would be, something of benefit. So we also know that volunteers have been shown to improve outcomes for older adults in other healthcare settings. So very powerful effects of volunteers helping people in hospitals who are acutely ill to prevent delirium. So the Hospital Elder Life Program, some Dementia Day programs, there was research on volunteers there. Volunteers themselves benefit from volunteering. So most volunteers feel that it helps with their mood, sense of purpose, gaining experience for work or school, a chance to give back or contribute to something that is important to them. And already a lot of nursing homes, most nursing homes have volunteer programs, but a lot of our programs weren't directly involved with people with dementia, and I think all of our homes said, we could always use more assistance or volunteers. So in this pilot study, which I'm going to tell you about, we wanted to develop a training program for volunteers to implement some evidence-based non-pharmacological interventions for behaviors in dementia, be able to recruit and train some volunteers using this program, and then see what effects the program had on behaviors for people with dementia. So what I'm describing today is just an open-label study. So this is something we did at one nursing home. It's not a randomized controlled trial, but we have that ongoing now. And we recruited participants and volunteers in blocks of 5. And the reason we did that, as you'll see, the way we've designed the intervention is to try and decrease the burden of measurement on the frontline nursing staff. So if we do it in groups, it's a little less disruptive than doing it one person at a time or sort of at different time periods. But also our volunteers work as a team. So we need to have multiple volunteers working together in order to provide those activities sort of spaced through the week. So that's why we sort of did it in groups of about 5. And we worked initially with Extendicare in Kingston, which is a medium-sized nursing home. And it's open. There isn't a non-secure unit. There isn't a secure unit there, but so there's people with dementia sort of mixed throughout the home. And in terms of people that we included, it was people with dementia, who hadn't experienced a recent transition to long-term care. So we wanted people who were sort of had adjusted somewhat to long-term care, who had significant levels of agitation, no recent changes in behavior. We excluded people that we thought might be, difficult for volunteers and inappropriate for volunteers to volunteer with. And also people where we thought that there was something else that needed to get addressed first, like uncontrolled pain or other issues. For recruiting our volunteers, it was really, it's quite simple. 90% of our volunteers have been recruited through Kijiji, which is free. So we used Kijiji ads and some newspaper ads. We also put up posters, and we tried a variety of approaches, but really Kijiji was 90% of our volunteers. And then they register on a volunteer website. We screen them to make sure they're appropriate and also to give them an opportunity to ask questions about the project. And then they have their regular sort of volunteer background checks, their CPICs, health checks, that sort of thing. We pay for the CPICs as part of the research project, and actually the OPP and our local police waived the costs for most people because of it. And then we provide our volunteers with a 2-hour orientation and education session. So we talk about symptoms that they're likely to see with people with dementia, how to communicate, some suggested activities, and those sessions are facilitated with one of our staff, our psychogeriatric resource consultants, or registered nurse who are very skilled in providing education in behavioral management. So here's our Kijiji ad. It says, wanted, friendly faces to help people with dementia, and it sucks you in saying you're going to gain valuable experience and be part of a great team. It's part of a research team. We get, typically when we're running the ads, we get about 150 views a week, which is actually pretty, it was surprising for us. We're often oversubscribed initially with volunteers. And then once you click on the link, you go to our website, and you sign up here, and it sucks you in, and the next thing you know, you're volunteering in a nursing home. So our intervention, we ask our volunteers to come in about a morning or an evening once a week, and while they're coming in to visit, that they would visit with up to 3 people while they're there. And each person with dementia has up to 3 volunteers the same 3 volunteers, but up to 3 volunteers working with them throughout the week. And again, that's to try and provide a little bit of activity and stimulation at different time points in the week. We get a life history on each person who participates, and it's actually pretty easy to do because when we're getting consent from family members, we just spend about 3-4 minutes just getting a little bit of background information and some ideas about hobbies, background, occupation, and just even some tips from the family members about like what sort of things do you think might be good for your mom or your dad. And then our volunteers work with the volunteer coordinators in the nursing homes to provide activities that are tailored to the individual. Most of it's just pleasant conversation, just reminiscing, being present with the person, interacting with them. It's nothing too fancy. Sometimes playing games or accompanying them to other activities in the home. And we supply a project activities cabinet and supplies. Truthfully, we developed sort of a catalog of activities that we thought would be helpful. I think if we to make this fly in a routine setting, you'd probably need to spend maybe $200 or $300. So we've got lots of activities. It's really quite simple and inexpensive things that people are actually doing. So our outcomes, we look at behavioral outcomes, our main outcome being the Cohen-Mansfield agitation inventory, which most of you are going to be familiar with, along with a number of other outcomes. We also measure volunteers' quality of life, and we do some interviews with them to understand their experience. And in our pilot study, we had 10 people with dementia who were recruited to participate. Pretty typical, I think, of most people with dementia who have behavioral problems in nursing homes in terms of their age, mainly females. I think one thing that's interesting is most of these people are already on some drugs for their behaviors and were having behaviors as well. So when you see any additional effect, that's on top of a lot of medications to begin with. And we didn't exclude people based on whether they had medications. And in terms of their behaviors, at least Extendicare, they picked some really tricky cases for us. People who had fairly significant levels of agitation and behavioral symptoms. Our volunteers, so in our pilot study, we had 14 volunteers, that we trained. Most of them were students, and the majority were females. Later on in our subsequent studies, we've got a bit more retirees who've volunteered with the program than we did in the initial pilot study. But a lot of students, and in Kingston we have Queen's University, so a lot of the students are affiliated with them. Interestingly, we have some very highly trained students. So we've had students who are occupational therapy programs, people in RN programs, and they're really looking to get sort of hands-on, get their feet wet, and get some hands-on experience with working with people with dementia, because they know this is going to be a big part of their job. So we had some very talented, skilled people joining us, and as I mentioned, most of the recruitment came through Kajik. In terms of our pilot study, so with those 10 patients, they received 6,000 minutes of volunteer time. Most of our volunteers completed, so it was a 12-week study. On average, a lot of our volunteers completed about 6 of the 12 weeks, and some of those dropouts or people who weren't able to complete were anticipated because people going back to school or leaving, and we didn't want to exclude people, so we over-recruited to account for that. On average, when they did come to visit, it was for about an hour, and most volunteers provided about over 100 interactions or visits when they came. And most of our volunteer participants got about 10 hours of volunteer time, which is pretty close to what we wanted for a target. And just in terms of behaviors, our primary behavior of interest was agitation, and at most time points following implementation of the volunteer program, agitation reduced significantly. At the end of 12 weeks, the test was not statistically significant, and I think there's 2 reasons for that. We had 2 people who developed, and this has happened several times in the study, people who developed delirium. And their behaviors go up significantly, and it's not something you'd expect a volunteer to necessarily be able to help with. And I know we had a few individuals, but also some of this does reflect volunteer attrition. There was probably ineffective intervention. We know at least in 2 cases where we were able to step in and provide an additional volunteer or a new volunteer for someone who had dropped out, then the behavior subsided again. So I think some of this bump up is losing some of our volunteers, but also a few people who got quite behaviorally, had behavioral changes associated with delirium. It was a little less impressive in terms of the neuropsychiatric inventory, and that tends to measure other things like sleep and appetite and psychosis, and had a smaller effect, not statistically significant on depression, and no significant effect in the pilot study on quality. Our qualitative data was also very interesting. Our volunteers, they felt actually they got to know their participants, the people they were volunteering with, very easily. They all valued getting to know the person behind the disease and seeing the sense of humor that the person with dementia might have had, or those types of more personal things. They all felt they developed personal connections and a sense of responsibility to the residents they were working with, and they wanted to continue volunteering. We have a larger study ongoing now where we have control and intervention homes that we're evaluating, and we've had about 50 people, 50 volunteers and 50 people with dementia enrolled in that. I think we've got about 25,000 volunteer hours logged, so hopefully over the course of the next year we'll be able to see in a controlled study whether this holds up. But just to conclude, neuropsychiatric symptoms are common, as we know. These non-pharmacological interventions can have a big impact, and pleasant activities provided by volunteers might be one way to do this. So thank you.